Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Musa. Thank you, organizing committee. It's my pleasure to share this case. Sudden cardiogenic shock and pulmonary edema during primary PCI. This patient, 50 years old, Egyptian, male patient, diabetic, hypertensive, dyslipidemic, and known history of PCI and stenting 8 months earlier in Egypt for drug-eluting stents in a private hospital in Egypt, but we don't have the details of this procedure actually. Patient come to the emergency department, chest pain on and off for 12 hours, hemoglobin A1C 9, LDL 1.6, and echo 30%. ECG showed mild elevation in ST segment in the anterior leads with Q wave, or maybe late presentation, we don't know, but the patient coming in stress condition and in severe chest pain. So immediately I activate the cath lab for this patient and take him showing very tight in-stent restenosis in the proximal LAD and also very tight diffuse in-stent restenosis, multiple lesion in left circumflex. We noticed something here strange actually. Occlusion in the mid LAD. I thought initially this is probably the culprit for this presentation. And this is right coronary artery showing also in-stent restenosis in the mid segment, very tight segment. So this is what I thought initially, so I tried to cross this mid LAD with wire. I use initially BMW wire. It is tip of the wire damaged and buckled. I cannot cross, so I use cyan blue wire with a small balloon support, 1.5, also failed to cross. So in this situation and with this anatomy, I take very rapid decision to cancel trying more in this LAD and just optimizing this very tight in-stent restenosis in the proximal LAD and also left circumflex and refer the patient for discussion with the surgical team actually. So I use NC balloon 2.5 by 12 in the proximal LAD, improving of this stenosis, and by the same wire immediately because patient still distressed actually. By the same wire, I don't use both wire because there is no time, just I take the wire to the L6 and same balloon dilating the two lesion in the left circumflex proximal and mid lesion. And this after balloon dilatation. Improvement of severity of the lesion, I plan to abort here, stop here, and refer for discussion with surgical team. But the patient within a few minutes clinically become deteriorated and having shock and pulmonary edema. And this is initial baseline blood pressure, and this after he developed pulmonary edema with severe hypotension. So immediately I insert the intra-aortic balloon and patient intubated and we give norepinephrine. And this is the injection after we stabilize the patient, blood pressure become build up, and I finish the procedure and send the patient back to the CCU. In CCU, I reviewed the family again for the previous report of the PCI done in private sector in Egypt 8 months earlier. I get surprised LAD, it is CTO. And more surprised, I report that the PCI stenting done to left mean to diagonal branch, and they cancel PCI to LAD after failure to crossing this LAD. And here I should stop and mention a very important statement Dr. Kasem mentioned earlier this morning about the inherent bias of some people, because when this case referred from a small hospital to another hospital, the operators, after failure to open this CTO, he doesn't inform the family. and he insisted and continued to make left main PCI to diagonal and make the issue complicated for this patient. I think we should be honest with the patient and we discuss all the possibilities. Maybe surgery is much better for such cases, not biased because he feels shy to say, I failed to cross the CTO lesion. So I discussed the case with the family and with the surgery. The surgical team discussed with the family high-risk procedure, so the family eventually refused this high-risk procedure and accept PCI. I discussed with the family that we will do for this interstitial stenosis ballooning to RCA and possible stenting to the ostial LED and ostial circumflex. So I started actually with the simple lesion in the RCA, which is dominant actually, and after NSC ballooning and well preparation of the lesion and DCP, this is the final result of RCA. Then I come to the left system. Actually, it is narrow angle. It is ostial lesion, LED, ostial lesion, left circumflex. It is Medina 011 classification. So what is the optimal technique? I take my time to thought about the strategy for approaching. Of course, all of us know that the true Medina classification 111, 101, and 011. Our patients 011. Of course, the complex bifurcation anatomy by Medina, it is actually not take into consideration the bifurcation angle, calcification, lesion length, functional significance, and we have multiple strategies, and no single strategy fit all the anatomy of the bifurcation lesion. In this setting, actually, I decided to use simultaneous kissing balloon because this patient having EF 30%, just 1 minute or 2 minutes, please. Patient having poor LV function, 30% ejection fraction, and 1 minute, please. Yeah, so it is the patient having developed previous time pulmonary edema, pulmonary congestion, cardiogenic shock after just only ballooning to interstitial stenosis. So I want to make very fast procedures, not take long time. So I decided to make SKS technique, actually wiring both vessel, predilate as needed, position stent, deploy stent simultaneously, and perform kissing balloon. Of course, it depends on the side branch obstruction more than 50 and side branch size more than 3, and side branch angle should be a narrow angle actually. And when we should make SKS technique, non-left mean, long left mean stenting, uncertainty about debit, no true bifurcation disease. So, because of time, I pass all these slides. So I decided to make SKS technique, and it is actually modification of the V stenting. We should make little bit protrusion to the left mean. Then I deploy the kissing, the 2 stent, and then make final kissing balloon. Just last slide I will show.
Last slide. Where is the slide, man? Okay.
Short new carina, full coverage of distal left mean, and this is the final results. Then NSC ballooning of the mid left circumflex and optimizing with final kissing balloon, and this is the final kissing, and this is the final results of simultaneous kissing stenting of left mean. Of course, this is a very important slide from Sharma showing that precise SKS trial more effective and safe in terms of reduction of TLR, mean vessel angiographic restenosis, in comparison to conventional stenting. It is safe and effective. So, final take-home message: simultaneous kissing is not routinely recommended, but in some cases, especially critical cases, and the operator should have access to procedure 7 French, but I use 6 French by simultaneous advancing of the stent initially to LED, then after that the stent advanced to left circumflex, and final result was excellent. Thank you.
Shukran.